my colleague who cannot make it, Dr. Lau. Yeah, I'm the second author for this paper. We're going to present our modest experience again of needlescopic VATS pericardial window in our center. So we all know the pericardial window can be done for diagnostic purposes and therapeutic purposes, to get fluid and tissue for diagnosis of infection or tumor, also therapeutic to prevent tamponade and recurrence of pericardial effusion with symptoms. Classical approaches that we all know are things like anterior thoracotomy, subcostal or subxiphoid approach for the open, and we're all perhaps familiar with possible approaches with VATS, 3 ports or 4 ports with 10 mm or 5 mm instruments, and also uniportal pericardial window reported in 2005, I think, by Gaetano Rocco. We've modified the technique to use needlescopic 3 mm instruments to do the VATS pericardial window. So needlescopic 3 mm VATS pericardial window may be an attractive alternative to standard VATS. It perhaps has the potential for further reduction in ASCVTS trauma and also quicker recovery. Needlescopic thoracoscopic procedures is already well known for procedures like symplectomy, prothesis, lung wedges, and biopsies and resections, etc. So it's a proven technique. We aim to investigate the feasibility and the safety of performing needlescopic VATS pericardial window and reporting on technique and experience of this approach. So we've only had modest experience with 9 patients who underwent this technique between June 2011 and January 2013. They all underwent general anesthesia, double lumen tube or with a bronchial blocker, allowing single lung ventilation. The 2 positions that we use for this needlescopic approach, including the full lateral position with 30-degree table flex, or a semi-supine approach, and that's dependent on surgeon preference. So this is a full lateral position with a 10 mm incision for the scope at the apicostal space mid-axillary line. We use a 30-degree scope, and then 2 3 mm stab incisions for the instruments, one at the 6th intercostal space mid-clavicular line, and the other at the 6th intercostal space mid-axillary line. The alternative approach is to position the patient in semi-supine position with some support around the right side of the back. And with that, you can place 3 ports on the lateral aspect of the chest, in the patient semi-supine, 10 mm incision, again at the 6th intercostal space, 30-degree scope, and 2 3 mm stab incisions at the 4th and 5th intercostal space and 2 axillary line, respectively. So this is a brief video of the lateral approach.
This video shows a left needlescopic pericardial window procedure performed with the patient in lateral decubitus position and operating table flex at 30 degrees, with double lumen tube intubation and left lung deflated. The 10 mm port and 30-degree thoracoscope at the 8th intercostal space mid-axillary line, 3 mm instrument ports at the 6th intercostal space mid-clavicular line, and 6th intercostal space mid.
So with the 3 mm instruments, we can push the lung posteriorly and get away from the pericardium.
The pericardium is breached and a small.
And sorry about the sound. And we can make a small hole in the pericardium. You can see the fluid level just in the lower part of the video, actually, from the within the pericardial space. 3 mm instruments are obviously very sharp.
An endosucker is used to collect and save the pericardial infusion for analysis, and for improved drainage of the infusion to facilitate further dissection of the window. The endohook diaphragm can also be used to expedite the dissection.
So we're basically performing the same operation as in an open, and can be taught to trainees quite easily. So it's a simple procedure.
The pericardium specimen is retrieved through the 10 mm port using 3 mm endo forceps under direct vision, sharing the port with a 5 mm thoracoscope. The procedure is completed with the placement of a 24 French chest drain through the inferior thoracoscopic port towards the index and secured with O-silk suture. single 409 nylon suture is applied to each 3 millimeter incision.
Okay, so the results for 9 patients were 6 males and 3 females, and the mean age was 67 years old, range of 48 to 78. 7 patients already had no malignant pathology before we had the operation. 5 of those were on the left side and 4 on the right side, and the mean operating time was around below an hour, 45 minutes on average. The intra-pericardial fluid that managed to drain was around 370 with a range of 200 to 750 mils for the patients. In 2 patients, there were moderate adhesions, and we were able to take down the adhesions of the lung to the anterior chest wall and pericardium with the 3 mm instruments. Surgery successfully completed for all the patients, and the mean post-op chest drain duration was around 3.5 days in a range of 2 to 5 days, and there were no post-op complications or 30-day mortality. We did a simple VAS pain score following the chest drain removal, which was average around 2.2. So in terms of whether needlescopic VATS is really beneficial in terms of pain and access trauma, I think I can only find one paper in the literature which compared needlescopic VATS sympathectomy against standard VATS sympathectomy, and there was no obvious difference in post-op paresthesia at a follow-up around 3.5 years. So needlescopic VATS on the surface appears that it's associated with less access trauma and better cosmesis with smaller wounds compared to conventional VATS or open, but whether it's associated with quicker recovery, patient satisfaction, or less post-op pain or complications is really unknown. So in conclusion, needlescopic VATS pericardial window for malignant benign pathology can be a safe and effective procedure, and in our experience can be taught easily to trainees as a training for VATS, getting used to VATS procedures, and the long-term outcomes and potential benefits of this technique warrant further investigation. Thank you very much.
Thank you very much. And I'll talk to this.